I just wanted to reflect on, and hopefully this will be a theme over, later tonight and tomorrow. Again, the extraordinary opportunities right now that are presenting themselves to us with this new science and new technology and new opportunities for patients. It is a weight. There's a huge weight on with all of patient advocates in collecting the right data and being able to share it. It is complex, but what we're trying to do and work together is help create these approaches and you'll see over the next day, templates and ways to decrease some of the heaviness and the weight and the complexity so that we can make this path forward for patients with all of these opportunities, make it a little bit easier, if that's the right word. But anyway, so big data, we're talking about data, and I would like to introduce, you guys will be able to introduce yourself. I'm gonna walk off the stage.
Keep going.
No. So I'd like to introduce our friend and board member, Wendy Erler, from Alexion. If you could do the honors and then introduce Kirk, and I will let you guys take it away. The next is big data. Can it supercharge what we know now are 10,000 rare diseases? Plus.
Thanks, everyone. And I have to just take a minute and say I'm awestruck by how full this room is and how exciting this is. And to think about where RareX is going to take the collective intelligence of everybody in this room is amazing. So as Nicole said, I have the privilege of serving on the board of RareX. And why did I join the board? Because Lord knows we all have a lot to do. It's because I believe in this. I believe that if we can put all of this data in one place and use it in the right way and do everything that was just talked about in the previous session, we're going to drive dramatic change for patients and improve care and access to meaningful therapies. But it's going to take all of us. In my work life, I lead the patient experience team for a rare disease drug development company, and I have experience working in, I just counted up last night, 26 different rare disease communities. So I'm super passionate, and I'm not nearly as smart as the people that use all these big data words, but I really believe in making sure patients have a voice at the table. And Kirk?
I'm Kirk Lamoreaux. I have about 25 years of healthcare experience. I'm the co-author of the RareX report, The Power of Being Counted, and my background is large pharma, Pfizer for about 16 years, and have been a consultant for a variety of different biotech and health systems for the last 10 years or so.
And a great partner. So we want to talk about something really, really exciting and game-changing, and thinking about why does big data matter? And some parts of this are pretty simple, right? Like we can talk about genomics and proteomics and all those really heavy science fields. Some of this really gets down to what does it mean to be counted? And as Kirk said, we had the privilege of participating in some research that led to some really exciting information. What's the challenge? 1 million years ago, someone really smart named Nicole Boyce stood up in a room and said, there's X number of rare diseases. And that number took off like wildfire, partly because Nicole's so smart, but also because she really put a number to the problem. There are a lot of rare diseases. So for decades, everyone's used this matter-of-fact assumption that there are around 7,000 rare diseases. You see the number kind of vary between 5,000 to 8,000. Sources of these estimates are a little bit nebulous and hard to identify, and given that there's a lot of diagnoses and rare diseases within rare diseases, it just became very complicated. But the bottom line is the estimates really haven't changed. So when we were talking at RareX about what does it mean to have data and federated patient data and all these bold ambitions that we have as an organization, we realized we really needed to do a job around what is the more accurate count of the number of rare diseases today and offer patient communities recommendations for being counted. Why does it matter? So we set about with this lofty goal of what do we need to learn, what hasn't been updated in all these years, and then how do we talk to patient advocacy groups and patient communities about why it matters. So our findings, after probably about a year of work, Kirk, is that there are closer to 11,000 named rare diseases. 20% of conditions are so poorly described that there really isn't a medically actionable path. So those are the patients and caregivers that sit in front of a doctor who kind of throws up his hands and says, it's all in your head, or something equally unhelpful. There's also a path that most rare diseases follow that take it from really unknown to a condition that is well understood. And that path has lots of hills and valleys and different steps, but it's a path and it's pretty tractable. So if there's a readily diagnosed condition with a name and inclusion in this database of named conditions, that's the first step on a path. For some psychological reasons, to be able to say to a family, you have this condition and it's called this, and you're one of however many in the world, there's a lot of power that gives a diagnosed person or a caregiver, but it also really puts action behind this path of next steps and how do we get to a meaningful therapy. So while big data may really put some conditions on the map and move them forward and really get a lot of action behind them, it really does start with being counted, and this can help successfully lead to investment in research and potentially new treatments. Kirk?
Yeah, so one of the foundations for our work was basically trying to reconcile existing knowledge bases. And the two primary ones for rare diseases are OMIM, which focuses on genetic conditions maintained by Johns Hopkins, and then Orphanet. So we have a brilliant colleague of ours, Sébastien Lefebvre, who was our data scientist who really did the number crunching. And so a lot of props to him for his work. But what he started to do was to leverage the hierarchy in Orphanet. We wanted to balance our ability to count all rare diseases without duplicating the count. And so we took a look at the hierarchy of Orphanet, and we basically decided to count all of the children. So there's parent and children relationships for some disorders. If there was, we took the children. We then looked at the existing mapping of OMIM to Orphanet, and we looked at those that were exact matches, and we excluded them. We looked at those that were a more narrow match, so an OMIM condition that didn't quite match up with Orphanet, that was a little bit more narrow. We added them in, and then we took a look at that subset of conditions that remained. That was just an OMIM condition, not reflected in Orphanet. And those three numbers really kind of make up the 10,867. And that's how we arrived at it. We recognize that this is a dynamic number. It's going to continue to change and evolve, but it does represent, I think, tremendous progress in the rare disease community over the last, 5-6 years that we should be able to celebrate. And our call to action with this report is largely to get more and more disease groups and advocacy organizations to embrace this number so that we can advocate for the types of resources that we as a community need.
So Kirk, if I could summarize, are you also saying that the methodology that was developed really ensures everyone is counted but not double counted?
That's correct. We tried to identify each of the various sub-levels without duplication. So one of the key things that we also tried to do, which is a little bit unique, was we tried to take a look at how well described a condition is. And first of all, I want to acknowledge that we recognize that this 10,867 number excludes many conditions that have yet to be added to a major knowledge base. In our conversations with the geneticist at Johns Hopkins, she recognized that probably less than half of the people that she sees, a little under less than half, actually have a condition that still isn't in OMIM or Orphanet. And so there's tremendous work that needs to be done. But we do recognize that just as a patient has the diagnostic odyssey, the therapeutic odyssey, and hopefully they end up with the treatment, diseases kind of follow a similar progression from obscurity into one that is added to a knowledge base. It may not be necessarily well described. It could be from a case report, small cohort summary. But eventually we start to attract more patients. We can understand it a little bit better. And then from there, ultimately we can hopefully become a diagnosable condition, and then one with treatment. Now, our delineation of between poorly defined and well-defined is fairly arbitrary. Similar to like using literature reviews to try and estimate point prevalence for incidence and prevalence, we basically took a look at the number of associated HPO terms with each condition. And if it was less than 3 HPO terms, we designated it as poorly defined. If it was more, it was technically diagnosable. And again, we recognize that that is, again, fairly arbitrary, but it was our attempt to try and add some color to what is the extent of the challenge and what are the gaps that we as a community can work together to try and solve. If a physician cannot diagnose a condition, if there aren't enough phenotypes to do a differential diagnosis, then oftentimes it's going to be missed. And we know that, most importantly, in order to arrive at a treatment, it is important for the researchers, the investors, the drug companies to be able to understand the underlying underpinnings, the genetic underpinnings of a condition, the phenotypic expression, incidence, prevalence, a host of different things in order to make it attractive. And I don't know if you have more details. We've had some fascinating conversations with researchers and individuals that are in charge of R&D, but I think that was one of the key things that stood out, is that understanding the underlying nature of that condition is absolutely essential to determining where research dollars go. And so helping individual disease communities progress through the steps is absolutely critical.
Yeah, and I think one of the things we heard in many of the interviews is that then there's a druggable target. So a number and a name kind of adds up to informing prioritization for a druggable target.
Yeah. So this just kind of breaks down some of the statistics that gives us an idea. Total conditions, we found that there are about 87% of them are actually genetic or known genetic conditions. When we take a look at the poorly defined conditions, the majority of them still remain to be genetic, but we see about 37% of them are non-genetic. And then in those diagnosable conditions, we see that the majority of those diagnosable conditions are genetic. And again, part of that is because of our methodology. You know, if there was a gene associated with it and some phenotype, then that got you, a little bit further down the road. But again, this is something that helps us to understand the extent of the challenges that we have. And we do believe that there are some catalysts coming that are going to be able to help accelerate our ability to identify more patients for conditions, whether that's the introduction of ICD-11 codes that will help make it more computable, helping us to understand the clinical outcomes and the economic resource utilization of some of these conditions. That's one component in the next 5 years. I think that there are a whole host of population genomic programs, including genomic newborn screening programs being rolled out here in the US, over in Europe as well, that have tremendous potential for us to add additional color and understanding of the nature of some of these genetic conditions. And I think these are things that have some promise for us.
So what are some of the recommendations specifically for rare disease patients and advocates? If there's a condition that's kind of in that uncounted area, we talked about that as emerging. And there's some really concrete steps, and I should mention that as we went about writing this paper, we interviewed and included patients, patient advocacy groups, policy experts, clinical experts, geneticists, so there was a lot of expert insight that came into this paper. And in thinking about that emerging disease area, the number one recommendation that was made was to really find your community. Seeking out patients with a similar genetic variant, sharing learning, sharing knowledge, sharing any research data that's available, using platforms like Matchmaker Exchange, internet searches, blogs, and social media. And another idea that came up in our interviews was really tracking family history, like being vulnerable with people and saying, my brother has this and my sister has that, and these are the symptoms, and connecting those dots. A lot of that burden sits on the patient community in this emerging area. Engaging researchers who have published on your condition, finding that champion who's written that esoteric paper, because those are the people that are going to help put a real framework behind the condition in a publication type perspective with data and information. And then make yourself known to those who have previously published. Make yourself available, share your blood work, share your information. That adds a lot of oomph to any work that might be done. In the poorly defined area, there's an opportunity to get sequenced. If your condition is suspected of being genetic, but a specific disease-causing gene isn't really identified yet, you need to get sequenced. That information may not be super informative today. It could be very informative tomorrow. We're learning something literally on a daily basis as far as genetic sequencing. And Kirk mentioned whole genome sequencing in newborn screening. So there's a lot of work happening very, very early as well. patient-led research or citizen science has been incredibly effective. So by being counted and being included with a name in the rare disease universe, there's an opportunity to go from poorly defined to diagnosable, which is the third category. So understanding how biotech and life science companies actually make R&D investment decisions is critical. And there's a talk about this tomorrow. Excuse me. But there's part of that work is really being able to bring information to the table that helps a company prioritize researching in your disease. Be clinical trial ready, have natural history data, have whole genome sequencing information, be clinical trial ready. Provide physicians with better tools to diagnose, treat, and manage a certain rare disease. Some of that falls on the patient community to really have burden of disease information or a sequelae of symptoms that could lead to a diagnosis and providing that information. Partnering with drug companies to be able to deliver that information. And then build the evidence base of treatment effectiveness. So these are some recommendations. There are a lot more in the paper. And then what are the implications for the rare disease ecosystem? As important as this nearly 11,000 number is, finding that 20% of rare diseases are so poorly defined that they are medically not actionable represents an incredible responsibility. It represents opportunity to make this better, to change this, to really have a story to tell patients and families that there's a reason for hope and a way to potentially develop a meaningful therapy. And then calls to action in the report are really intended to help communities organize and feel emboldened and empowered, and to share information in developing a publication strategy so that the literature can truly reflect accurate advances that are happening today in disease understanding.
One thing I do want to point out is that, we know that advocacy communities are extremely resource constrained. Oftentimes they don't fully appreciate that even though a condition may be, for example, represented in OMIM, it may not be an orphanet. And we talked to some communities that would, basically they were trying to engage and had correspondence with orphanet, and they were frustrated that they didn't get anywhere. Communities didn't understand that the way for them to get into the knowledge bases is through peer-reviewed information that was curated by experts. This is one of the key bottlenecks as we talk about big data. It's one of the biggest challenges that I think will occur as we start to have a much more dynamic flow. But it is important for people to realize that OMIM and Orphanet rely on peer-reviewed journals in order to take that information and to incorporate it into its sources. And without that, it just does not get in there. And that was one of the opportunities that we thought was important.
Excellent. Any other comments you want to make for implications for the ecosystem?
Nope.
So the Be Counted paper has been published. We, as Kirk said, we do have a call to action if patient advocacy groups and other pharmaceutical companies could start to use the updated number. We know there's power in being counted, and we really need that unified voice. One of the other things that we learned in all the interviews and in preparing the paper is that there's a real need for pharma and biotech to help communities target their limited resources and research efforts for maximum effect. And so how can we come to the table with patient advocacy communities to talk about what type of information pharma needs to actually prioritize looking into a certain research process for a certain condition. So that was another kind of big learning from this work, is that there's a way to help patient communities prepare information that speaks the same language as the drug developers. So we'll turn it over if anybody has any questions. Yeah.
Because it was so good. Oh, God. Bruce.
I do feel like I'm at a wedding reception with all these roses on the table.
So pretty.
Uh-oh, Kirk.
Thanks for all the hard work. I'm over here, Wendy.
I can't.
I'll stand up.
Oh, there you are. Hello.
Okay. Thanks for all the hard work, and this is really great. So what can those of us in here do to, besides starting to use the information and go from 7,000 to almost 11 or more than 10 or whatever the number is, if you want us to use the exact number. What else can we do to start amplifying this message so that it not only does the accurate number become known, but some of the information that's in here starts to get out to, to people who have the power to make some differences in here. Funders, companies, patient advocates, room is filled, but it could be a million times fuller and we'd still be missing people. So what are your suggestions for what we should do?
So great question. I think we'll both take a stab at answering it. I do think sharing the paper and getting the word out is critical, and that's on all the channels we all use, fill in the blank, social media. Because that really does, when we first published the paper, there was a lot of traction, and we all got a lot of calls about what does this mean, and we can amplify that. I think the other, you mentioned a lot of stakeholders. Getting this to policymakers is going to be critical, so identifying whether it's meeting opportunities or presentation opportunities to do that, that's another opportunity. And I think in the communication around being counted, there are two key pieces of this. One is the actual, why does it matter to be counted? And the second is, it's almost 11,000 today. We know that that's only going up. Rare disease is a worldwide public health crisis. And why is it important to be counted? Because then everything comes behind it. Research dollars, investment, process changes, the list goes on and on. So there's a responsibility on each of us to get the word out.
I think the other opportunity is for those groups that are actually more mature is to mentor the newer groups, to basically help make them aware of this pathway forward so that they can utilize their limited resources in the most effective way. So they can kind of develop targeted research strategies, partner with academia, make sure that they're able to get published information and strategically move the ball forward. I think that's one area where those that are more seasoned can take an active role. And I think that, yes, it would be nice that everybody would be able to reach out to you, but sometimes if you find that there are adjacent, more relatively new diseases, that might be an opportunity to make them more comfortable with this information.
Thanks for all the great work. Just question on the cadence of which you're going to rerun this process, because I think that's a really powerful thing to have, multiple points making that line.
So Seb's not here, so we'll volunteer him. That's a question we're asking ourselves too, and I don't think we have a very clear answer right now.
I think that number one, it is worth doing because it helps us to, again, mark our progress. And it is something that we're in discussions with an external party, and I think I'll defer to Nicole and Charlene to talk more about perhaps future plans for that. My mic gets cut off at that point.
Yeah. No, you're not getting cut off. I think we can say it. So, okay, go ahead.
Yeah, Wendy, Kirk, thank you. It was implicit in what you said, but in the spirit of why we're all here as the users of RareX, I think one thing I'll flag, and maybe Nicole, we think about this for next year, is the importance that us as RareX users and the RareX community converting the data in RareX into peer-reviewed publications. I think that's going to be a big next step for us with RareX, and then, of course, everyone in this room is a user of RareX.
Excellent, thank you. To your point, and to the point about continuing, we are in discussions with NIH and NCATS that have been analyzing and evaluating the algorithms and kind of the process, and the hope is that they'll actually take this and move it forward and kind of own that new number. So just know that those discussions, we're knee deep in those discussions. The last, is there any other questions? Okay.
I just want to add to Nicole's point, anecdotally, they've been really impressed with the methodology. So we took a really complex problem and broke it down, and when we went to NCATS and NIH, they were really impressed with the methodology, which is why the conversations have gone as far as they have.
One more question.
Quick question, from our standpoint, and that forced me to go back to OrphaNet and OMIM, which I haven't done in a while. And we have a lot of peer-reviewed publications that obviously aren't in there right now. And how can a small organization take the steps to make sure that the information in there is appropriate? I mean, obviously work with your researchers, but do you have any
Is that something
quick
Seb
and
could
dirty
help with?
suggestions?
You know, as we spoke with Anna Rath from Orphanet, or we spoke with Ada Hamish from OMIM, you know, it really, one of the key bottlenecks is the process of going through the literature by their expert panels. And so, you know, they do try and stay on top of it, but it is becoming overwhelming. And, you know, they not only have to review it, but then they oftentimes go deep into the information included, and they have questions for the authors, and they send back, you know, questions that they want to have clarification because they identify certain errors. So they are the gatekeepers. They take their role seriously. They are resource constrained, and that is one of the limitations of keeping this information up to date. So,
You know, how can we, is there any way we can make it easier for them to make sure? Because there's a lot of dated information I just found the last 10 minutes.
Yeah, so I would tell you that that's a really good question, and let us take that offline, and then Nicole, we can follow up. We have a colleague who works very closely with both organizations, so we're going to go ask them what we need from all of you to make it easier, and then we'll come back.
So fabulous work. I second the motion to do this on a regular basis, you know, annually or every other year. But a question, so 8,000 was the number that we used to sort of cite, and we also said, you know, about 30 million people in the U.S. with rare disease. Did that number also change with the increase to 10,867?
Yeah, because that's in the paper.
yeah, I mean, we still use the 33 million number for the U.S. Based upon rare disease estimates here. So that did not change.
But we did look at it, and we anticipate with the actual number of diseases being identified going up, that's probably going to increase over time.
Before we say thank you, and I know that we're at time, one of the things that you said that I think is really important to tee up tomorrow is you talked about the importance of disease description. And the basis to a lot of that is data and why that's so important. And so I know that there's several sessions tomorrow and things that we're working on that is working to help support patients in being able to do that. Because it's kind of a foundational need for interest and future work with researchers. So that was like a big, huge takeaway from us when we you know, kind of saw the data and started talking about the importance of disease description and what we need to do to solve that. I don't know if you have comments.
Just that data leads to publications, which is part of the proof source of moving the engine forward. So it all goes hand in hand.
Awesome. Thank you so much. Let's give them a round of applause. All right, you guys, so that was a very quick kickoff to Exchange, the Patient Innovator Forum. Thank you so much, Wendy and Kirk. We are going to excuse all of us to move out to a reception that we're hosting in partnership with Global Genes. It's sponsored by our friends at Horizon, and it will be out in the grass area outside the conference center where a lot of the other lunches, et cetera, had happened earlier in the week. Tomorrow, as you can see, we're starting bright and early. So be here at 7 for breakfast. I'm being bossy right now. We're going to start promptly at 7:30, and you don't want to miss the kickoff for tomorrow. So we have a really, like we said, intense day. Again, bathroom breaks are going to be on your own. And we have the really cool roundtable sessions that will also bookend the day tomorrow. That will be really roll up your sleeves, deep dives in some pretty extraordinary topics with real amazing experts, many of who will have participated today. So we look forward to seeing you tomorrow. Thank you guys for sharing yourselves with us tonight. And thank you again, and we'll see you outside, and looking forward to seeing you tomorrow morning. Thank you.
I'm used to it by now.